In this, the final installment of this series, we're going to focus on one more aspect of alcoholism treatment: the high rate of concurrent psychiatric problems experienced by alcoholics. Although our progress in understanding alcoholism has yielded some great successes, ironically, it may have also clouded some of the original vision. The medical community has long considered alcoholism as a serious psychiatric disorder.
Like schizophrenia, depression, anxiety, and bipolar disorder, alcoholism also has a genetic component that causes changes in the chemistry of the brain. However, the rise of specialized alcoholism treatment programs has in part separated alcoholism from other psychiatric disorders in the minds of many treatment providers. Although these specialized treatment programs have led to improvements in the treatment of alcoholism, they have also contributed to a gap between alcoholism treatment and treatment of other mental health disorders. This gap is a serious issue because alcoholism and other psychiatric disorders often occur together.
Unfortunately, approximately 1 in every 3 patients receiving treatment for alcoholism also suffers from a serious psychiatric disorder. And conversely, about 1 in 3 patients with a psychiatric disorder also experiences problems with alcohol.
Providing diagnosis and treatment for these patients is a significant challenge. For instance, are they drinking because they're depressed, or are they depressed because of their drinking? Or could it be that they are both depressed and alcoholic? Even for a professional, these questions can be daunting, to say the least. But for the patient, these concerns can lead to a big red stop sign on an already bumpy road to recovery.
Coming up, we're going to learn more about treatments for psychiatric disorders and how they relate to alcoholism.
Research has shown that alcoholics are 2 to 3 times more likely to suffer from a serious psychiatric disorder than the rest of the population. These disorders include depression, anxiety, phobias, bipolar disorder, and schizophrenia, and they affect about 30% of all alcoholics. Although it's unclear why alcoholics are more prone to these psychiatric disorders, studies show that bipolar disorder and schizophrenia, as well as some forms of depression, have important genetic components which, much like alcoholism, impact the chemistry of the brain. To make significant gains in their treatment, many alcoholics will need help with both their alcoholism and their psychiatric disorder. For an example, research has shown that if an alcoholic who is also suffering from depression does not receive treatment for their depression, they are significantly more likely to relapse to heavy drinking. The same is true for psychiatric patients who also have a history of problems with alcohol. Alcohol abuse can slow progress in the treatment of their psychiatric disorder, as alcohol has been shown to reduce the effectiveness of some prescribed medications, resulting in more frequent and longer hospitalizations. Unfortunately, treatment providers for mental health care and treatment providers for alcoholism each tend to focus on their particular areas of specialization. Therefore, it's not uncommon for mental health care professionals concentrating on psychiatric disorders to pay inadequate attention to the diagnosis of alcoholism. Similarly, alcoholism treatment providers focused on drinking behaviors may not identify psychiatric problems. Treatment providers in each field have their own unique terms for these multifaceted patients. Alcoholism treatment programs most commonly refer to them as dual diagnosis patients. The correct classification of dual diagnosis patients presents a considerable challenge for even the most skilled practitioners. For example, chronic alcohol abuse can cause symptoms that are very similar to those caused by other psychiatric disorders. Therefore, it can be a challenge to differentiate symptoms resulting from chronic heavy drinking from those that are not caused by the patient's drinking. Because of this similarity, most practitioners are reluctant to diagnose an alcoholic with another disorder until that person has been sober for at least 4 to 6 weeks. Ironically, sobriety can further confuse things. Because abstaining from alcohol can alleviate some of an alcoholic's psychiatric symptoms, some practitioners have come to think of sobriety as a type of dual remedy. But unfortunately, this failure to correctly identify and treat dual diagnosis patients can quickly lead to further and far more severe consequences.
Although medications are widely used for the treatment of psychiatric disorders, the concept of using prescription drugs to treat addictive behaviors is, for some people, a controversial notion. Earlier in this series, we saw how the drug naltrexone may help reduce cravings in alcoholics by limiting the amount of dopamine released into the reward pathways of the brain. Now let's take a look at some of the medications prescribed for 4 serious psychiatric disorders: schizophrenia, depression, anxiety, and bipolar disorder, to learn how they may impact the treatment of alcoholism.
Like naltrexone, most medications for psychiatric conditions also work by affecting the levels of several key neurotransmitters. Drug treatments for schizophrenia have improved in recent years. In the past, the most effective treatments were 2 medications called haloperidol and chlorpromazine. Both of these drugs worked by blocking dopamine receptor sites in several areas of the brain. Drugs that work by blocking neurotransmitters are called antagonists. We know that alcohol and all other drugs of abuse create their feelings of pleasure by causing the release of dopamine in the reward pathways. However, dopamine antagonist drugs have little or no effect on drinking. To explain why, we're going to use a lock and key analogy, with the neurotransmitter depicted as a key and the receptor site shown as a lock. While our brain has only one type of dopamine, shown here by several identical keys, it has many slightly different types of dopamine receptors, shown here by the numerous locks, in the same way that a master key can open several different but similar locks. Clustered together, the different types of dopamine receptor sites are associated with different types of brain activities, ranging from how we think to how our bodies move. Like a master key that can open all of the different types of dopamine receptor locks, dopamine affects a wide range of behaviors. This is where drugs like haloperidol and chlorpromazine come into play, but instead of acting just like the dopamine master key, they are specific to only one lock, that is, to just one type of dopamine receptor. Haloperidol and chlorpromazine are a good fit for the dopamine receptors that control our perceptions and interpretations of reality. But these medications are not a good fit for the receptors associated with feelings of pleasure, which is why these drugs do not affect the euphoria derived from drinking alcohol or taking drugs. While dopamine antagonist drugs have been a powerful treatment for schizophrenia, it has recently become clear that dopamine is not the only neurotransmitter involved with this disorder. Serotonin, a neurotransmitter that helps control our moods, is also closely associated with schizophrenia. Some of the newer antagonist-type medications, such as clozapine and risperidone, work by blocking both dopamine and serotonin. There are 2 neurotransmitters that play an important role in depression: serotonin, which helps to control moods, and norepinephrine, which impacts our ability to concentrate. The most prevailing theory as to why some people develop depression is that their serotonin or norepinephrine neurons are not functioning properly. To understand this, and to gain an understanding of how antidepressant medications work effectively in treating depression, we must first review how neurons work. When a neuron fires, it releases neurotransmitters into the synapse. These neurotransmitters bind to receptors on neighboring neurons, and in doing so transmit important signals which tell the neurons to increase or decrease their activities. Once the message is delivered, the neurotransmitters are released from their receptors. These neurotransmitter molecules must now be quickly cleared out of the synapse, or they will continue to bind to receptors over and over again. This will disrupt the neuron signaling process and prevent the brain from functioning normally. One of the ways the brain clears neurotransmitters from the synapse is through a process called reuptake. During reuptake, the neurotransmitter molecules are recycled and taken back up into the firing neuron, where they are either broken down or made ready to be used again. Almost all antidepressant medications work by blocking this reuptake process. Most antidepressants, such as fluoxetine and sertraline, very specifically block only the reuptake of serotonin. Coincidentally, some studies have found that sertraline and fluoxetine may help to reduce cravings for alcohol and the severity of relapses. Normally, blocking the reuptake process would cause the brain to malfunction, but a depressed brain is not a normal brain. Blocking reuptake forces the neurotransmitter to stay out in the synaptic cleft, which causes additional messages to be sent to neighboring neurons. For the receiving neuron, being bombarded by all of these extra messages is just like having the volume on the radio turned too high. The neuron's response to all of these extra messages is to turn the volume down by reducing the number of receptors for the neurotransmitter. This is a common process called down-regulation. Down-regulation is part of the brain's way of maintaining a normal level of activity. So through a series of chemical events, antidepressants work by ultimately causing down-regulation. That is, a decrease in activity in the brain pathways which control our moods. People suffering with anxiety disorders feel very high levels of stress, and as we know, one of the ways people relieve their stress is to turn to alcohol. As we saw earlier in this series, one of alcohol's primary effects on the brain is to cause ion channels controlled by the neurotransmitter GABA to leak negative ions into neurons throughout the brain. Negative ions make neurons less likely to fire, which decreases certain brain activities, which reduces how stressed we feel, while at the same time increasing our feelings of relaxation. That's how alcohol relieves stress, and it's also very similar to how some medications relieve stress. Some of the most prescribed medications for anxiety disorders make up a family of drugs called benzodiazepines. These medications all work by binding to receptors on GABA ion channels, causing the channel to remain open longer when activated by GABA. The result is that more negative ions enter the neuron, just like the effects of alcohol. So, just like alcohol, benzodiazepines make neurons less likely to fire. And as with alcohol, the result is the same: relief and more relaxation. These similar actions on GABA ion channels is why physicians often prescribe benzodiazepines to help ease alcohol withdrawal symptoms. They can be used to help neurons adapt to the lower levels of negative ions seen during withdrawal in a gradual and controlled manner. Bipolar personality disorder may be the psychiatric disorder most commonly associated with alcohol abuse. Treatment for bipolar disorder often involves the medication lithium carbonate, and while it has been studied extensively, it is still not entirely clear how lithium carbonate actually works.
Most current thinking on how lithium carbonate works suggests that it changes the functioning of the brain by affecting ion levels. One way that it may do this is by stabilizing neural membranes, which in turn affects the function of ion channels. There is also some research suggesting that lithium carbonate modifies serotonin levels, while other studies suggest that in some way it makes overactive nerve cells less likely to fire. We've learned that, like alcoholism, some of the most severe psychiatric disorders, including schizophrenia, depression, anxiety, and bipolar disorder, have a genetic component that changes the chemistry of the brain. And for psychiatric disorders, the use of medications is commonplace. But for alcoholism, the use of prescription drugs is still an evolving practice. And finally, we've learned that medications used to treat psychiatric disorders work by affecting the levels of several key neurotransmitters in the brain. It's interesting how certain drugs can target particular areas of the brain and impact specific human behaviors. But even though we've learned more about dual diagnosis patients and the medications that are used for certain psychiatric disorders, there are still fundamental questions to be answered. For example, which disorder usually happens first, the psychiatric problem or the alcoholism? And does it even matter? To answer these questions, let's take a closer look at the relationship between alcoholism and other psychiatric disorders, and why certain treatment providers struggle with prescription medications as a treatment option.
For many dual diagnosis patients, the nature of the relationship between their psychiatric disorder and their alcoholism is unclear, and it is important to understand that there are many instances where a patient's psychiatric disorder and alcoholism are not related. These individuals just happen to suffer from two severe problems at the same time. But it is also clear that one disorder affects the other, as increased drinking can cause or worsen psychiatric symptoms and lengthen psychiatric hospitalizations, while worsening psychiatric symptoms can make abstinence an even greater challenge. One of the more familiar theories explaining why some people with psychiatric disorders also abuse alcohol is that they are trying to self-medicate their psychiatric symptoms by drinking to feel better. But unfortunately, while consuming alcohol may have begun as self-medication, for many individuals the drinking takes on a life of its own. For these dual diagnosis psychiatric patients, research shows that treatment with the appropriate medications may greatly reduce the severity of their psychiatric symptoms, but may have little or no effect on their drinking. Which is why for individuals who began drinking to self-medicate, their psychiatric problems are probably best viewed as a risk factor for the development of alcoholism. Another theory explaining the relationship between psychiatric disorders and concurrent alcoholism puts a twist on the concept of self-medication. It's thought that instead of drinking to help alleviate their symptoms, some dual diagnosis patients turn to alcohol to actually enhance their symptoms. For example, some individuals suffering from severe character disorders feel a certain rush from acting impulsively. For them, drinking to excess enhances those feelings, promoting their impulsivity. As we saw earlier in this program, some alcoholics who develop psychiatric problems may see a remission in their symptoms soon after they quit drinking. But some other alcoholics are not so lucky. For them, their chronic alcohol abuse may have led to psychiatric disorders that linger long after they become abstinent. Unfortunately for these individuals, they may have been genetically predisposed to a particular psychiatric disorder that was triggered by their severe drinking. A thorough psychosocial history, paying particularly close attention to the timing and onset of both the psychiatric symptoms and the progression of alcoholism, is very important. But regardless of their etiology, dual diagnosis patients with their complex and intertwining symptoms present a significant case management challenge, particularly if they require medication. For a variety of reasons, many physicians are hesitant to use medications to treat alcoholics with concurrent psychiatric disorders. One common reason for their reluctance is the potential for abuse. This concern stems from the fact that many alcoholics have long histories of using drugs to modify their moods. While it is true that some psychiatric medications, particularly those used to treat anxiety, can be abused, most psychiatric medications have little or no abuse potential. Another concern is the potential for toxic drug interactions. Some treatment providers are concerned that the use of medication during a period of heavy drinking may cause toxic interactions between alcohol and the medication. Although this could happen with some medications, it is usually possible to avoid toxic interactions and prescribe medications that are safe, even in combination with alcohol. Treatment providers are also concerned with medication non-compliance. If a patient has relapsed, he or she may start taking their medication intermittently. With some medications, intermittent use can sometimes be worse than not taking the medication at all. Fear of enabling drinking is another issue affecting a treatment provider's decision whether to treat an alcoholic's psychiatric symptoms. Because drinking causes many of the psychiatric symptoms experienced by alcoholics, some treatment providers view these symptoms as another example of alcohol's negative consequences. If it's true that alcoholics usually quit drinking because these negative consequences have become too much to handle, then removing consequences will make it easier for them to continue to drink and less likely that they will choose to abstain. In other words, some treatment providers believe that treating alcoholic symptoms may prevent them from hitting bottom. It is important to note, however, that this view has not been evaluated scientifically and is probably inconsistent with a treatment provider's goal of relieving suffering. Ultimately, it probably doesn't matter which symptoms came first, those of alcoholism or those of another psychiatric disorder. What really matters is that both problems receive careful evaluation and treatment. Otherwise, dual diagnosis psychiatric patients will continue to drink because the medications they receive for their psychiatric problems may have little effect on their drinking behaviors. And dual diagnosis alcoholic patients in alcoholism treatment will not be able to focus or abstain long enough to gain the coping skills that they are being taught.
We've learned that while there are several theories concerning the relationship between psychiatric disorders and concurrent alcoholism, there is no definitive answer. However, we do know that treatments for psychiatric disorders often have little impact on drinking behavior. Although treatments for alcoholism appear initially to help concurrent psychiatric disorders by promoting abstinence, if left untreated, the psychiatric disorders can lead to a relapse. We've also learned that although there are several reasons why some treatment providers are reluctant to prescribe medications to treat dual diagnosis alcoholics, research has shown most of these concerns to be unfounded. Finally, and most importantly, we've learned that the most effective treatment for dual diagnosis patients lies in the careful evaluation and treatment of all disorders. For treatment providers, this may mean a need for more training to gain a more comprehensive understanding of psychiatric disorders, including alcoholism. And for the 1/3 of their patients with a dual diagnosis, recognition of both problems makes for a smoother ride down the long and sometimes confusing road to recovery.